So this talk was inspired by, really working in the lab the last month and a half or so and seeing all the interesting structural cases that come through. So I'm hoping to showcase some of the work done by our structural team and then some of the excellent images acquired by our sonographers. So I have no disclosures, but much of what I'll be presenting is, from trials that have been funded by the device companies. The devices start as investigational before they become FDA or Health Canada approved. So there's just that caveat in mind. And so today we're going to look at a potpourri of intracardiac devices in various positions. We're going to talk about all the devices that you see on your screen here. And we're going to discuss some of the procedural aspects of device deployment and as well as important factors in follow-up. So the objectives today are to review unique cases from the St. Michael's Hospital Echo Lab and Structural Program to describe the rationale for device choice in the management of valvular heart disease, to appreciate pearls and tips in image acquisition and interpretation for structural heart cases. And so some of the devices, as I mentioned, are approved for commercial use, and then some of the devices are investigational. But as Dr. Chow said, like a lot of these devices are now, we do the procedure here, but the patients go home and they live all over Ontario and then certainly across the country and across the world. So you'll likely see some of these devices in your labs, especially over time. And so just going back to the first principles, with prosthetic device evaluation, think of it, although these devices are placed through a transcatheter percutaneous approach, think back to first principles. So if you were describing a prosthetic valve, describing how the device looks, how is it seated, is very important. Transvalvular gradients is also important to assess for prosthetic valves, whether they're put in percutaneously or surgically. And then intravalvular and paravalvular regurgitation is also important to describe. So these are kind of basics, and I know we all know this stuff, but it's important to describe when you're seeing any prosthetic material within the part. And then, we're going to talk about some of the expected and potential findings. So for example, if, a patient who has a MitraClip or a transcatheter mitral valve replacement, the way that's put in is through, initially through venous access. So there's a transseptal puncture. So a lot of times, an expected or potential finding is these patients will have an iatrogenic ASD. So that's something to kind of look for and to describe. But it's also important to think about complications of the various devices and whether that's just because of how the device is seated or the patient's anatomy. And we'll talk about some of that today. So the first thing we'll talk about is mitral transcatheter edge-to-edge repair. This is something that we're probably most familiar with because it's been around the longest. And essentially what this is clipping the leaflets, the anterior and the posterior mitral valve leaflets, to create a tissue bridge to try to reduce the degree of regurgitation. Historically, the MitraClip has been what's used, but the Pascal device has just been approved by Health Canada. And so, likely people have seen MitraClips before. And the edge-to-edge repair, it's safe. It's a procedure that has a low complication rate. It's well tolerated, and you can generally reduce the degree of mitral regurgitation significantly. There's often some degree of mitral regurgitation that remains. You don't abolish the regurgitation, but you reduce it, and that can be enough to help the patient feel better. And so this is an example. This is a video from the Abbott, for the makers of the MitraClip, and it shows just kind of how the procedure is done. So through a transfemoral approach, through the femoral vein, the right heart is accessed. A transseptal puncture is made, so going from the right atrium to the left atrium. The transseptal puncture is wired, it's dilated, and then the steering system for the clip is actually able to be placed within the left atrium. And the clips shown on the left side of the screen, you try to line that up with where you want to clip the leaflets together. That can be in the A2 P2 position, A3 P3 position, whatever will give you the best result in terms of reducing the regurgitation. And so the steering system has some sophisticated features to try to line the clip up properly. And it has these two clasps on the top you can see going down there. And the idea is that the bulkier part tries to grab the leaflets from the ventricular side. The clasps try to grab it from the atrial side, and then they clip together like that, and that creates a tissue bridge. And if the result looks good, then the clip can be deployed. So this is a nice kind of 3D conceptualization of the clip procedure. You can see here there's now a tissue bridge. And the regurgitation will be reduced. So there's a lot of data on MitraClips. This is provided by the makers of MitraClip, and it looked at the expand. So this was real world contemporary use of the MitraClip device, and it found that the degree of mitral regurgitation reduction was significant. So for these patients, about 90%. 88 to 90% had mild or trace mitral regurgitation at the 30-day mark. And then safety, 96% of patients were free from any device-related complications at 1 year. And complications can include single leaflet device attachment, which we'll talk about, as well as device embolization, which are very, very rare. And so edge-to-edge repair has made its way into the guidelines. So the AHA 2020 valve guidelines have provided indications with a Class 2A recommendation for the edge-to-edge repair for both primary and secondary mitral regurgitation. So primary when there's a problem, with the valve leaflets in and of itself. And so these are for patients who are at high risk. So your patient who has, let's say severe prolapse, they're too high risk for conventional surgery, and edge-to-edge repair is recommended with a 2A recommendation there. And then for our patients with LV dysfunction and persistent symptoms despite skyline-directed medical therapy with secondary MR from that annular dilation, leaflet malcoaptation, if the anatomy is favorable and they meet these LV and systolic dimension and PA pressure cutoffs, then edge-to-edge repair is recommended with a 2A recommendation. So this is an example of a patient with, on the left side of the screen is pre-MitraClip procedure. You can see the patient has LV dysfunction. The left ventricle is dilated. Looking at the top left of the screen, the leaflets are apically tethered, and there looks to be a small malcoaptation gap with severe eccentric mitral regurgitation. And then post-clip on the right side of the screen, you can see there's a clip attached to the anterior and posterior leaflets, probably at the A2P2, and the degree of mitral regurgitation is reduced significantly. So this would be a good result. Again, as a reminder, always important to interrogate for gradients through these. So this is a CW through the mitral valve where the clip is, and where they have good flow going through the valve, and the gradients are measured, should be reported. And so this is a patient who has primary mitral regurgitation. You can see that there's severe bileaflet prolapse, and that's on the left side of the screen. And you can see the resultant very anterior eccentric severe mitral regurgitation. And so this patient was too high risk for surgery, so they underwent MitraClip. I thought this was a rather interesting case because you can see on the right side of the screen, the clips, well attached to both the anterior and the posterior leaflet, but it moves quite a lot. And that's probably because the valve leaflets are still prolapsing. Certainly the base of the leaflets are prolapsing, so there's a lot of movement there. But this within the study, they interrogated this clip in detail. It was felt that the clip is still attached to both leaflets. It just moves a lot because the actual valve leaflets move quite a bit. You can also see that the degree of regurgitation has been reduced significantly with the procedure. This is a short axis for the same patient on the left side of the screen, and you can appreciate how again that that clip really moves quite a bit. But again, it looks like it's attached to both the anterior and the posterior leaflet, and this is demonstrated in the apical views as well. You can see it prolapses with the leaflets that prolapse, and the degree of regurgitation is overall reduced and mild here, at least in the chest that we can see. So this is a different patient. So this is a gentleman with a cardiomyopathy, an LV dysfunction, who underwent a MitraClip procedure, was doing well, and then was discharged and came back to hospital with decompensated heart failure. And on the left side of the screen is a short axis loop showing it's frozen. But you can appreciate how there are two clips. They look to be in the A2, they'll be attached to P2, P3, but they don't really seem associated with the anterior leaflet. And when the sonographer sweeps through the short axis, you can appreciate that there's a significant MR jet that's very wide that goes just above where those clips should be tethering the two leaflets together. When compared side by side, this was concerning for a single leaflet device attachment. So this is a four-chamber view of the same patient, and you can appreciate just how much those clips move. And in fact, one looks like it's prolapsing through the valve annulus into the left ventricle. And when color is applied, there's a severe jet of MR. So this patient ended up undergoing a TEE, which confirmed a single leaflet device attachment. And so this is a complication of edge-to-edge repair where the clip is only attached to one leaflet. And risk factors include poor leaflet integrity, a large coaptation gap, or poor initial grasp.
I think one of the other things too on that is, if you go back to the previous image, it's probably not really A2P2, isn't it? It's more medial there, and
it's more the Ruiz you're saying.
Commissural grasps are much more difficult because there's a lot more caudal involvement there, and we don't image them as quite as well.
Yeah.
So I think it's all we call it tiger country. As soon as you start getting competitions, you've got to be much more vigilant and concerned that the risk for either getting a grasp that's not perpendicular to the valve, so malalignment of the grasp, which will then lead to residual MR, or in fact grabbing cords instead of the tip is a real concern there. So
absolutely,
a lot of investigators won't go for commissural grasps. So if I remember with this case, this person had no other options, and it was done as a bailout, and there was risks were known at the beginning, but it is a worry.
Absolutely. Thanks, Dr. Connolly. And that's actually a good transition to the, talking about the Pascal device and kind of where that may fit in the landscape, because this device was just approved by Health Canada. There's the regular Pascal, and then there's the Pascal Ace. The Ace is what's been used at St. Mike's so far. It's a thinner device. And so there's some differences in the engineering of the delivery technology. So in terms of how the device is deployed, maybe I'll just go to the next slide here. Because one of the features that is described with this device is that it has this ability to go from the closed state, which we're familiar with what it looks like on TTE, to the leaflet capture states when it's trying to capture the leaflet to this elongated state. And so the idea is that when you're trying to capture and you're trying to clip more commissural, you're at risk, as Dr. Connolly said, of getting entangled within the cords or perhaps only capturing cords. And so if you stay in this leaflet capture mode here, you're certainly at higher risk of getting entangled. And so with this, the engineering for this clip is such that it can become elongated and straighten out as shown here. That can help get detangled from any cords and then allow you to come back into the atrium and reset. So there's changes with this clip that really try to make it perhaps that's where it'll fit in the landscape, is for the treating more commissural disease. The Class 2D trial looked at the Pascal device versus the MitraClip, and found that really the degree of MR reduction was similar at 1 year. Then there were no differences in terms of mortality, hospitalization for heart failure, NYHA class. So they seem quite comparable in efficacy. And the first device was put in last week here. This is after Health Canada approval. This is Dr. Pham, Dr. Ong, Dr. Bisleri, and the Edwards team after their clip. Now we put in these devices from an investigational point of view, but this is the first Health Canada approved one. So pretty cool. And so again, this is a patient who had a clip in the A3, a P3. So you can see it's more clips more to the septum in the short axis view. And so again, that's maybe where this clip will fit in because of the steering and engineering changes to it. And then on the right side of the screen, the sonographer sweeps through the four-chamber view here, and we can see that when the aortic valve, the LVOT is opened up, we don't see the clip. And as they pan more towards the threes, you see the clip come into view, and there's overall probably mild residual MR there. And so this is a patient who underwent implantation of a Pascal ACE. You can already get a sense that all the chambers are dilated here. There's apical tethering of the leaflets. There's a degree of mild to moderate LV dysfunction on the left-sided image pre-clip with a very eccentric and a severe jet. Without even dropping the baseline, you can see a piece of shell. And then on the right side of the screen is after implantation of a Pascal ACE, and the degree of MR is reduced significantly. What was also found on this study is, on the top row is Definity contrast shots of the patient's LV function, the 4s, the 2s, and the 3s prior to edge-to-edge repair, and then in the bottom chamber, in the bottom row, you see the 4s, 2s, and 3s post edge-to-edge repair, and you can see, visually, and then what was quantified is that there was a decrease in the left ventricular systolic function after edge-to-edge repair. And so why might this happen? Well, there's a concept called afterload mismatch, and the idea is that the mitral regurgitation is probably offloading the left ventricle in a way. The pulmonary system is a lower pressure in systole compared to the aorta and the systemic pressures. And so when you reduce that degree of mitral regurgitation, it may reduce the left ventricular systolic function. And various definitions have been proposed for this, like a drop in EF more than 50% from pre-procedure, or increase in diastolic volumes. And we have to remember, this is, even though the EF goes down, the effective forward flow is increased because you don't have so much regurgitating into the pulmonary system. The forward flow is increased. And so the blood pressure often improves after these procedures, even though the EF can go down. And so various numbers have been quoted. There's a study from 2020 that looked at 62 patients undergoing MitraClip. It found that 23% of patients met criteria based on the LV reduction. So something that may be seen. And certainly when the regurgitation is abolished in a patient who has, a TMVR or the valve is replaced, and you go from severe to trace or trace regurgitation, the risk is probably a little bit higher. We'll talk about that next week when we look at the right ventricle and tricuspid cases. So another expected finding for edge-to-edge repair is, as I mentioned before, is an iatrogenic ASD. And so this is a really nice example of a patient post-clip and the subcostal view of the interatrial septum. And you can see that there's a colored jet going from the left atrium to the right atrium. And this doesn't happen in all patients. Sometimes they close up on their own, but something you may see is worth hunting and commenting on in the report. And so this is showing some procedural images for a transseptal puncture. So this is a TEE. So just recall that the right atrium's down here and the left atrium's here. And so within the septum, it's landmarked, and so some X-plane, the changing of the angles is shown here, and they try to landmark about 4 centimeters above the mitral valve annulus to provide adequate clearance to deliver the device. And then the transseptal puncture is performed. So this is actually going through the atrium in the bottom left image loop here. So now we've crossed, and then on the right side of the screen, the iatrogenic ASD can be dilated to then allow delivery of the deployment equipment. And so I thought this was an interesting finding. So this is a patient who had a MitraClip procedure performed, and they also had severe tricuspid regurgitation. And so the idea was treat the MR first, and then see what happens to the TR. And as the case was finishing, the ASD was examined, and you can see here that there's a bidirectional flow, and that's shown really nicely in the color Doppler. And in systole, you have flow from the right atrium to the left atrium as it's above the baseline. And so, is this of clinical significance? Well, yeah, it certainly can be, because now you have bidirectional flow. This can be, this can lead to shunting of deoxygenated blood from the right side of the heart to the left side of the heart. It can also be a source of paradoxic embolism. And so, in this case, after this was identified within the same procedure, the ASD was closed. So that's why you may sometimes see these patients come back with ASD closure devices post MitraClip. They don't all, but if they identify this bidirectional shunt, that's maybe why they'll come back with it. And so this is an example of an amplatzer closure device going in. In the top left loop, the device with docking system being lined up. It's now open on the left atrial side in the lower left picture, the lower left loop, and then it's being closed in the a larger image on the right side to both the left and the right atrium. And so this is now color flow, and you can see that there's some color around and within the device, but nothing that actually passes through from the right to the left side of the heart. And this is a nice 3D reconstruction of the amplatzer device. And so you may see this in the follow-up transthoracic echocardiogram. You can see this patient, so just looking at the left image, the 4-chamber. So they have large atria, right? You can see attached to the mitral valve, there is a clip there. You can see a pacemaker lead going through the right ventricle, towards the right ventricle through the tricuspid valve. And then you can see in the anterior septum this bright ASD closure device here. And then this was interrogated in the subcostal views. The subcostal views were challenging for this patient. But you can see we don't really appreciate any color flow from the right atrium to the left atrium here. And actually, just going back to that loop for a second, you can appreciate how there's around that pacemaker wire, around the tricuspid valve here, you can see this jet of tricuspid regurgitation. And so it makes sense, if they still have significant TR, and then you had a hole right here where that bright ASD closure device is, you could see how you could shunt through, right?
We've also seen that, Mike, where I think the added flow actually then in someone who's got a bit of a RV that's borderline can then further promote RV dilatation. It's acting effectively as an ASD.
Right.
We've had a number of cases where we then had to go back and the TR has increased. So we've treated the left side of the disease and now we're stuck with that. But despite that, we think part of the mechanism, as you know, there's obviously dedicated trials looking at devices that will create an iatrogenic ASD in the absence of MR. And we're involved in a couple of those currently. So we try not to close it. Usually we look for early desat. But if they're not desaturating early, we generally do not. Just sort of saying, then we monitor clinically and see how they go. It's a bit of there's not a lot of science
guidance,
but clearly people desaturate early, then it is a hemodynamically significant ASD, you have to close it. So we'll see what the data looks like just with these dedicated iatrogenic ASD devices. I don't think we really know.
Awesome, thank you. So we're going to change gears a little bit and talk about TMVR for the last half of the presentation. And so just keeping things in terms of sort of big picture, TMVR can be used in patients where clip is not visible. So for example, let's say you have a big dilated annulus, you have a significant coaptation gap. The leaflets are of poor quality for grasping. These are patients who could benefit more from a TMVR than a clip because the clip is just not feasible. The other piece is that the mitral regurgitation with the TMVR is generally abolished, so not just reduced, but it's generally minimized to trace. And so if that's the desired outcome, then a TMVR can be considered. Just keeping in mind these are more complex procedures and higher risk to the patient and the ventricle. So this is an example of the Sapien M3 system. So we're probably familiar with Sapien devices as kind of being one of the common TAVI valves, but the M3 is a device that's designed for the mitral position. You can see it looks like the Sapien valve, where it has this kind of stent, and then within that there's a valve, but it has this skirt that's sewn around it. And so that's different as opposed to the Sapien, which I'll show in some other later on in the presentation, that's open, has this skirt here. And then this valve, because we're replacing this within the mitral valve annulus, that is not like a aorta that's calcified and that you can deploy a device in. The annulus is much softer, and so you need something to kind of anchor it in there. And so this is a clever design where you have this docking system, and that's this coiled part here that first gets implanted into the patient, and then the M3 valve is deployed afterwards, and I'll show a video of that just now of how that works. So again, a transeptal puncture is made. The docking system is inserted, and it coils around. And then the Sapien valve is lined up, and it's expanded. And the docking system expands a little bit, creates some pressure, kind of like a little cinch to kind of wrap it around. It helps keep it in place. So these are some procedural loops of this actually being performed. So on the left side is a TEE, and you can kind of appreciate, there's this 3D structure here that's kind of coming into plane, and you see it on the X plane. And then on the 3D view on the right side, so we're looking at this is the mitral valve, looking at it from the left atrial side. This is the aortic valve for reference, and this is the coiled dock starting to be coiled around the mitral valve annulus. And so this is a 3D of that dock now that it's been placed. You can see around the mitral valve, it just looks a lot chunkier. It looks a lot more full. And then there's actually this anchor part that comes up here, and we can appreciate that anchor. So that this anchor right here, where my cursor is right here on the fluoroscopy. That's sitting in the left atrium. So this is fluoroscopy of the dock being placed in the top right. You can see it kind of turning and coiling into place, and then in the bottom right, the dock's now in place and ready to receive the valve. And this is a 3D reconstruction of the valve being placed. So looking at the 3D, this is the dock is around here, and then the valve deployment structure goes through that dock to then deploy the valve, and the patient gets rapidly paced, much like with a tabby. They get rapidly paced to allow a period of cardiac standstill to then allow the valve to be deployed. So that's what's shown here in this 3D. And then this is fluoroscopy showing the same thing from a different modality and in a different angle. And so on the left side of the screen, the dock is in place, and the valve is being lined up, and the balloon's being inflated, and the valve's being expanded. And then on the right side, you see the valve's been expanded and deployed. So multiple imaging modalities are used to help perform these procedures accurately. And this is this is post valve deployment. This is analogous to a 3-chamber view. The left atrium up here, the mitral valve here, and then the left ventricle, the aortic valve. And you can appreciate how there's now this stent structure within the mitral valve annulus. That's a stent from the valve. And then there's the valve leaflets here. There's a trace bit of regurgitation right here. So overall, a really good result. And so this is a transthoracic follow-up of the patient. And so you can appreciate how in the parasternal long axis, how much that valve stent really kind of goes into the left ventricle. You can also appreciate here where my cursor is, how much that stent comes close to the interventricular septum and how it can encroach into the LVOT. And so that's an important concept we'll talk about today. And then in the short axis view, you can appreciate just this round circular stent sitting within the mitral valve annulus. And that's the frame of the Sapien valve with the leaflets within it. And so this is a 4-chamber color compare of the same patient. And so you can appreciate the frame here, and then the leaflets within the frame. And with the color compare, we can see a trace amount of intravalvular regurgitation and a trace amount of paravalvular regurgitation on this view. One thing that may catch your eye is the device rocking. Is it well seated? It kind of catches your eye, right? But you can actually see the annulus. The whole mitral valve annulus looks like it's kind of moving and jiggling a little bit. And so assessing, for device how well it's seated is important for any prosthetic material. In this case, it was felt that it was kind of moving with the annulus and was overall stable. So what if you have a patient who has a failed bioprosthetic valve? So this is a patient who had a bioprosthetic mitral valve replacement over a decade ago, who the device has now failed. There's severe intravalvular regurgitation. This was interrogated and felt to be related to mitral valve leaflet perforation. So what can we do for these patients? Well, they have the valve in there, so they already have an anchor to kind of put a valve in. So a valve-in-valve, a transcatheter mitral valve replacement can be performed. And so in this case, a Sapien valve was implanted, Sapien S3, so the TAVI valve was actually implanted into the pre-existing bioprosthetic valve annulus to then replace that valve and reduce the regurgitation. So on the left side, you see that there's the patient's pre-existing bioprosthetic valve. You can appreciate the leaflets opening here. And then there's this going through the valve, and this is then lining up the new valve, the new Sapien valve within that pre-existing bioprosthetic mitral valve. And you can see that after deployment, the frame of the Sapien and the previous bioprosthetic valve really become one. And there's a little bit of trace paravalvular regurgitation here, and maybe a little bit of intravalvular regurgitation as well. But the degree of MR has been reduced significantly. And so this is a follow-up transthoracic echocardiogram for this patient. And one thing that kind of catches your eye is, the LVOT looks small here. In systole, at least in this angle, the interventricular septum looks like it's pretty much touching or almost touching the valve frame. And when you put color through that, you can see flow acceleration through the LVOT. And it almost looks like there's a Pisa shell right where my cursor is. So LVOT obstruction is something that's important to assess and follow up echocardiograms for patients who have had a TMVR. It's something that goes into the planning stage. It's extremely important. CTs are performed, tons of measurements are made to ensure we get the right valve and ensure that we don't cause LVOT obstruction. But it's something that needs to be screened for and assessed for. This is, I think, a really nice. I'm going to pause it here actually for a second. The sonographer does an amazing job here, sweeping through the valve and just showing how, in the short axis of the valve, you can appreciate how we're going to move to systole. Look how small that LVOT gets, how close that septum comes to how close it comes to the valve frame. I'm going to play it again. And so because these devices are bulky and they're not sewn in, they ride a little bit low, LVOT obstruction is something that a patient would be at risk for. And so this is an apical 3-chamber. The LVOT again looks small here, and when a CW Doppler is put through it, a gradient is found up to 63 millimeters mercury. And this patient ended up undergoing other transcatheter procedures, and this gradient eventually improved. But the take home here is, to a patient with a TMVR, really interrogate that LVOT. And so this is a different patient who's had a mitral valve repair years ago and did very well, but then developed a severe mitral regurgitation. And with their repair, the posterior leaflet was resected, and the anterior leaflet, which is quite long, remained, and a ring was placed. They did very well for a very long time. And you can appreciate in this view how short that posterior leaflet is here. Again, this is a TE. This is the posterior leaflet. This is the anterior leaflet. You see how long that anterior leaflet is. And you can see how it almost touches the interventricular septum of the LVOT here. And then the whole MR jet, because it's quite eccentric, is not shown here. But there's severe mitral regurgitation. So they have a ring. Can we just put a valve in a ring? Is this going to be a problem for the patient? Well, the long anterior leaflet, if a new valve is put in here and you have the stents that come into the left ventricle, that anterior leaflet can actually be pushed into the LVOT and cause obstruction. So this is something that's very important in the planning stages for such a procedure. And so what was actually performed for this patient is an electrocautery procedure. So this is a very, very interesting technique where use of an intracardiac electrocautery device to actually cut and lacerate and create a little perforation in the anterior leaflet was performed. And so this is a TEE of the patient. The cautery is sort of being lined up with the anterior leaflet on the left side, And then these are transgastric views. So this is your left ventricle. And on the X-plane, you see the left ventricle. And the cautery pierces right through that long anterior leaflet. This is the anterior leaflet here. And the cautery is just pierced right through. Yeah. And so the leaflet's now been perforated. And what's performed, and this is shown nicely with the fluoroscopy, is a little maneuvers done that cuts that anterior leaflet. And so the idea is then you've created a focal perforation and laceration within that anterior leaflet that can help to reduce the degree of LVOT obstruction, because now that anterior leaflet, instead of being one piece, is splayed, and that can help to reduce the degree of mitral regurgitation. And this technique has been well described in TAVI for patients. When you're pushing that aortic cusp leaflets back, your risk of obstructing the coronary artery ostium. And so laceration procedures have been performed in that setting to help reduce the risk of obstruction. And so it's been applied to the mitral. I thought this was a very interesting case. And so now the valve has been placed, and you can see that, this is the aortic valve, this is the mitral valve, left ventricle, and so this is the LVOT where my cursor is. And you can appreciate how there's some flow acceleration through the LVOT here. This is the valve deployed within the ring. And this is deep transgastric showing the LVOT. And there's, again, some flow acceleration from either that frame or that anterior leaflet. There's some flow acceleration where my cursor is here. And so this is the follow-up. This is the transthoracic echocardiogram the day after. I think what's kind of catches your eye here is that you see the frame of the Sapien valve, but you see this, and so this is that anterior leaflet, and you can just see how long it is, and it kind of just wiggles there, and it wiggles around the LVOT. And at least in this short axis view, we don't appreciate any significant flow acceleration, respecting that it's perpendicular to the probe. And then in the 5-chamber view, I didn't include the color picture here, but in the 5-chamber view, this was very well interrogated by the sonographer, looking for LVOT obstruction, and the highest gradient that could be found was 19 millimeters mercury with a Valsalva. So the procedure seemed to provide success. Is that that bulky leaflet remained, but perhaps it was splayed enough that there didn't seem to be significant LVOT obstruction in this case. And we thought that this was a very interesting case. So in the last couple of minutes, we'll talk about a few of the other TMVR devices. The Intrepid is a device that has a internal stent with a bioprosthetic valve that sort of is similar to the Sapien, but its anchoring system or its docking system is all in one piece, and that's this flexible brim, and then it has these spikes and hooks that try to hook into the mitral valve annulus, and this can be sized to match the patient that you're trying to treat. This is some data from the Apollo trial, and just shows that the degree of mitral regurgitation is reduced significantly at the 1-year mark with this device. 96% had none or trace, which is an excellent result. And the device overall is, at least based on some initial early safety outcomes, looks safe. So this is some intraprocedural shots of the device being put in. This is MPR multiplanar reconstruction. This was used to help guide this device. So this is the device being lined up from the LA to the LV, and the device is being lined up there. And then this is now the brims. So those brims of the valve are being opened up here, and you can appreciate how it kind of looks almost like a flower in the 3D view, how it kind of expands out. And then this is now the valve itself has been opened. You can see the valve leaflets within the internal stent, and then on the 3D view, you see nicely these spikes of the internal stent correlate to the spikes seen up here of this internal stent in the cartoon. And the degree of regurgitation, although not shown on color here, was reduced significantly. These are some follow-up shots of the patient, and you can see it looks pretty similar to the Sapien valves. It's kind of a long internal stent. You don't really see the brims very well; they become adherent to the left atrium and the annulus. So you don't see the brims as well. And again, we appreciate that there's kind of is it excessive movement? Is this rocking? Is it just moving with the mitral valve annulus? It's probably just moving with the mitral valve annulus. But that's something that you may appreciate as well. And then the last we'll talk about is the Tendyne. So this is a valve that has been around for a while. One of the first kind of TMVR devices described. And so the design of this is it's a very unique sort of design where you have this outer parachute layer that will stick and adhere to the mitral valve annulus and the left atrial side. There's an internal valve within. It then has these metal struts down here, and then it's tethered to the LV apex. So this is actually, and I'll show in this video here, this is actually performed through a transapical approach. So it's called transcatheter, but thoracotomy is done. A hole is made in the chest, and the apex is pierced to actually allow delivery of the device system. So you see here through that transapical approach, going through the mitral valve, a wire is first wired, and then the delivery system is lined up appropriately. And then the valve is deployed and opens up, and it's kind of a flower. And that parachute part catches the left atrium, and what then holds it into place is deployment of the tether. And so that tether will then go back towards the apex. Once everyone's happy with how the device looks and is secured, the tether will then go back to the apex. And that provides tensile force to keep the valve in place. An apical cap is applied, and the patient's thoracotomy is closed. The valve functions well. So this has been studied in the pivotal trial of this, looking at just patients who underwent Tendyne procedure. There was improvement in MR, improvement in NYHA class. There was 1% apical bleeding rates, and there's a trial ongoing that's looking at Tendyne versus MitraClip. That's called Summit. And so this is an example of intraprocedural images from the procedure being performed. This is with the transapical access. So where my cursor is, a wire is going from the apex through the left ventricle through the mitral valve. That's seen here. And then the deployment system is lined up much like you saw in the video. It's a larger caliber device, and it's lined up there. And then these are some 3D reconstructions of the device actually being opened up. So you can see here it's just starting to be opened up, and here it's being opened up and looks kind of like that flower being opened up here. This is again looking at the mitral valve from the left atrial view. And these are some 2D with X-plane looking at the valve being deployed. So here it's just starting to be deployed. Now the parachute is being opened up wider, and the parachute's in place. And the internal valve is being opened up. You actually the valve leaflets within the internal stent, and then again you have the parachute around it. And then the tether that goes down towards the LV, that tether will be secured with the apical cap. And so these are the valve being fully deployed. And again, you appreciate this design where you have this internal stent, these struts that go down towards that apical tether, and the leaflets, and the degree of regurgitation is minimal here. So this is a color compare from the transthoracic. And these shots can be challenging. These patients have undergone a thoracotomy, a small hole, usually in the apex, but still things can be a bit distorted, and so the shots can be challenging. Now what you see here is there's the valve annulus, the valve frame within the mitral valve annulus, and you see there's hints of that tether going towards the apex in the parasternal long axis view, and we don't see any significant regurgitation intra or paravalvular here. This is a short axis view, so you see these bright struts here correlate to the bright struts seen over here in the metal frame of the device. And then the tether goes down towards the apex when the sonographer fans down towards the apex in the short axis. You can see that tether going down in that direction. And then, as I said, the apical shots can be challenging, and it makes sense, right? You have this big plug there, and they've just undergone surgery. So that's just something to keep in mind with these patients who've undergone Tendyne. And so the last question I ask is, what happens if the Tendyne fails? And so this is a patient who had a Tendyne procedure, and in follow-up was found to have significant intravalvular regurgitation, which was symptomatic. You just appreciate how the color goes to and fro on the right-sided loop. So what do you do here? Well, you can put a sapien in that, and I say that casually, but we have to respect that this is actually a very complicated procedure because this patient has this cursor. This patient has this Tendyne in that has these metal struts that I'm highlighting here, and those can be sharp. And when you deploy this valve, it's deployed in a balloon, and so these metal struts can actually perforate that balloon. So there's a lot of planning that went into this procedure, but the procedure was a success. And you can see on the left-sided loop, you now have this sapien valve sitting within that Tendyne, and the degree of regurgitation is quite minimal. So this is a really good result. These are some fluoroscopy shots of the valve being deployed. So it's being now lined up within that Tendyne here. So this is the sapien and the Tendyne, and this is it being fully deployed. So wow, there's a lot going on in that patient's mitral valve. And these are the follow-up transthoracic echocardiogram. So you can appreciate how bulky that the metal frame looks now with the sapien in the Tendyne. You can appreciate that tether going down towards the apex, and there's a hint of regurgitation where my cursor is here that was felt to be likely paravalvular. But it can be really hard to know because there's just so much metal and shielding. And these are the apical shots for the same patient. You can appreciate how compared to the first shots I showed you with that severe regurgitation, the regurgitation has essentially been abolished here. So just some take-home messages, and then we can get to questions. Transcatheter edge-to-edge repair, it's effective when large coaptation gaps are not present, when the tissue is healthy and it's graspable, and edge-to-edge repair has a good safety profile. Mitral valve replacement is effective for patients who are not suitable for edge-to-edge repair, so has large coaptation gaps, poor leaflet quality. It has a higher likelihood of abolishing the MR, but it requires a supporting mechanism. So we've talked about kind of the docking systems. We talked about valve and ring. MitraClip is most widely used edge-to-edge device, but you'll start to see the Pascal, and where we think it'll likely fit in is due to differences in engineering, steering, and deployment that make it more attractive for commissural attachment. And transvalvular gradients are important for any prosthetic materials, so make sure those are interrogated and reported. And then sweeping to detect regurgitation, and that'll be one of the themes of next week, is extremely helpful for detecting regurg. Single leaflet device attachment should be suspected in a patient with significantly worsening MR after edge-to-edge repair, especially if the clip looks very, very mobile. And then we talked a bit about afterload mismatch as well, where due to the reduction of the mitral regurgitation, the afterload to the left ventricle experiences increases. And that's okay if there's a drop in EF because the forward flow is increased. But some studies suggest that this may actually be a higher risk feature, and these patients are at higher risk of mortality in the future. And that probably just indicates they have just a sicker ventricle if it wasn't able to compensate. Iatrogenic ASDs we talked about are commonly observed, but and try to look, and appreciate if there's a right to left shunting, because that could be of clinical significance. And then LVOT obstruction is something else that we talked about quite a bit today, and that could be because that TMVR scaffold, can encroach into the LVOT, and so that's something to interrogate. And the sapien valve, really offers a lot of versatility. It's a valve and a stent essentially, so it gives you a lot of versatility within the TMVR landscape. So with that, thank you very much for listening. I hope it was interesting. And next week we're going to ask, no, really, what am I looking at? So we're going to talk about some of the tricuspid devices that have coming through the valve, as well as maybe some plugs. So thanks for listening, guys.
So thank you very much, Mike, for this really whirlwind and lots of eye candies in terms of looking at the devices. And when our colleagues in the community encounter these images, it can be very, very confusing. So having access to the operative notes and the type of valves that they have is extremely important. The size is also important, so we always encouraged to document these devices, the name, the type, the model, the size, and date of implant if you have access to it, to be incorporated into the echo report. So without further ado, let's open up the floor to questions.
Yeah, Mike, Chi-Ming, it's Kim here. I think the point on LVOT obstruction with the valves is well taken, but just don't forget that we do see that with operative implantation of valves, and usually it's identified by the post-operative TEE, but it does happen from time to time. I've got a young gentleman who had aortic and mitral valve endocarditis that was extremely unwell and had to have an emergency bailout procedure.
Wow.
His aortic gradient, because of LVOT obstruction because of his mitral valve, is 150. Despite being on tiltiazem and Zoblok, he's completely asymptomatic. I've followed him for 7 years now. He has severe LVH and does not want another operation. So, and it was known at the time. So they identified it, that he was dying. So it was like, we're just going to leave his chest open, and if he survives, we'll deal with it then. But it is something that the anesthesiologist spent a lot of time looking at, depending on how you implant the valve. So it is really important, just with that approach, to document it, not only for these newer, bulkier valves, but also for routine mitral valve replacement. And usually what happens if it's identified, they'll go back in during the time of the OR, and if have to, they'll take the old valve out and replace it, because the LVOT obstruction can be really profound, particularly if you've got a hypodynamic ventricle.
Right.
So it is a problem. But again, just not to forget that it's not just related to these new types of valves.
Absolutely.
Actually, the early days of mitral valve repair, that long actually with mitral valve disease, LVOT obstruction, early after was a concern. That's when intraoperative TEs really started to be helpful.
Thank you.
That's great. And I love the animation that you put in. It really helps to understand what these devices look like, and also how they're implanted, and so on and so forth. And the proliferation of putting in these devices is no going back. I think you probably have seen a exponential growth of actually having these put in within GTA. We're going to have more institutions coming on board and doing more. Everyone sort of like started with MitraClip and then move on and put in other devices as they gain experience. So it's great for Canada. It's great for Ontario in terms of access. I think that the challenge remains patients having access to the family doctor, and then that's the major delay to coming to see us. Once we see us, then the delay would be having access to structural heart clinic, and then the delay will be having access to the lab and timing and the devices. So, but we're very fortunate to have a great team at St. Mike's. Our structural heart team is amazing, and we have lots of patients being treated both locally as well as around the province and even out of the province.
Absolutely, Dr. Chow. Let me see if there's any. I don't see any questions in the chat.
I don't see any, so.
But I think it's a really important point, Chi-Ming. The field's evolving so rapidly. I think one of the important things is we want to see patients sooner rather than later, because what we could do 10 years ago is not what you can offer now.
Right.
And I think it's evolving in terms of earlier intervention. We've got safer devices. The old patient with severe TR, we watched for 20 years and let them get the nutmeg liver and cirrhosis and renal dysfunction. We now have, as we're going to hear about next week, lots of opportunities. So, I think it is worth a referral to whatever your favorite structural program is, because there are a lot of things that can be considered. They might not be done. There might be other reasons, but I think early referral to get an opinion is where we want to push the field, because there are so many more opportunities. As you said, this is just a handful of devices that we're doing here. Around the world, there's dozens more that are coming, and we'll see who ultimately wins the race for the best devices. But it is going to change the field in the next 10 years dramatically. And I think, at the moment we do a lot of TE imaging. I think 4D ICE and those other modalities are going to come along as well and change the imaging component of it as well. But the high quality transthoracic echo before and after will always be the key imaging modality. The CT will work with it, but the transthoracic is key. So we've got to keep educating and evolving with the interventions.
Absolutely. Thanks, Dr. Connolly. No, I agree. I mean, I feel very grateful to be a trainee in this time and see how the landscape's changing, and excited for what comes next.